Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. For this episode of the Interventional Glaucoma podcast, we're heading to the European Glaucoma Society Congress in Dublin to join host Professor Gus Gazzard and guests Professor Christophe Baudouin, Mr. Ratnarajan and Dr. Miguel as they discuss MIGS and its impact on patients' quality of life. Let's listen in.
Welcome to the latest episode of the Interventional Glaucoma podcast series brought to you by Elios. My name is Professor Gus Gazzard and I'm very pleased to be able to bring you today three guests who are going to talk to us and discuss the impact of glaucoma plus and trabecular meshwork MIGS on patient quality of life in all its forms and in all its aspects. So first I'd like to introduce our guests today. Initially, we've got Professor Christophe Baudouin, who probably needs no introduction as a Silver Fellow of ARVO, Chevalier de la Légion d'Honneur in 2015. I'll have to excuse my French there. And author of well over 400 papers in ophthalmology, a true giant of ocular surface disease and glaucoma interactions amongst many, many other areas. Ratnarajan is a colleague of mine from Moorfields and Old Days, is now director of the glaucoma service at the very prestigious Queen Victoria Hospital in the south of England. And thirdly, we have Dr. Miguel, who is one of the foremost surgeons in France, introduced microinvasive surgery into Normandy, and is joining us here today with some great expertise and previous recruitments from randomized controlled trials. So thank you very much to all of you, and I'm looking forward to a great episode. I'd like to kick off really with a discussion or a consideration of what you think the burden of treatments for people treating their glaucoma are and how that might be impacted in the changing environment of this sort of phaco plus world that we have now. Professor Baudouin, Christophe, would you like to kick off?
Yes, with pleasure. It's clear that the main objective in treating glaucoma is preventing blindness, and the quality of life of the blind people is extremely low. But for that, we oblige the patient to use eye drop for decades, for all their life. And sometimes those eye drops cause major problems. For example, in the general population, dry prevalence is around 20%, which is high. And the burden of dry is very important. The impact of quality of life is very important. But in glaucoma population, it's more than 50%. So the difference is, of course, not due to glaucoma by itself. The disease has no reason to cause any dry, but the treatment. It means that preventing dry, allergy, irritation, conjunctivitis, blepharitis over time is very important for the quality of life of the patient, and all means to achieve that result, laser or other techniques, are of course welcome for the patient.
So that's over 50% of patients with glaucoma have some form of significant detectable ocular surface disease, is that right?
It's absolutely correct. 50% have clinically significant dry or ocular surface disease. We can add an additional 25% because when we use biomarkers at the level of the conjunctiva, we can observe inflammatory changes in those asymptomatic patient, but nobody knows whether the asymptomatic patient will become progressively symptomatic because of age, because of the accumulation of eye drops, or just the duration of treatment, and if the slightly symptomatic patient will become more severely affected over time. And this becomes really a problem for glaucoma specialists, because those patients with a later stage of glaucoma, more severe glaucoma, will require surgery. And surgery in a damaged ocular surface will be always a challenge.
Dirk, what's your take on this? Do you think that we're causing ocular surface disease? Is it something that we address sufficiently?
Yeah, I completely echo Christophe's points there, and I think we easily overlook it. You know, if you don't look, you don't see, and we as glaucoma specialists tend to be a bit focused on IOP or other metrics rather than these ones that actually really matter to the patients. That's what's affecting their quality of life. I think I'd also like to sort of touch upon the psychological impact of diagnosis. Once you tell someone they have glaucoma, it does change them. And I think putting drops in on a daily basis is a reminder to them that they have this chronic condition, potentially sight-threatening condition as well. So as well as all the sort of quality of life and ocular surface things, it's a sort of daily reminder of the condition they have.
I think that's a good point, actually. We underestimate the impact not just of diagnosis, but also of that daily reminder of our own frailty and mortality. It certainly applies to me with my anti-blood pressure tablets. Anyway, Anna.
Hello, thank you for the invitation. I'm very happy to be here in such huge names of glaucoma and happy to talk a topic of such an importance, right? So quality of life is absolutely everything. I certainly wouldn't like to live 2 more years with terrible quality of life. I would rather have just 1 year with a great quality of life. So I believe our patients feel this. There have been multiple studies on decreased quality of life in glaucoma, and you Professor Baudouin, have published lots and lots of studies about quality of life being even further decreased with ocular surface and eye drops, and they will cause failure to surgeries. So we really need to start thinking ahead and start intervening ahead to try to decrease this burden. And glaucoma is a silent thief of sight. You don't feel glaucoma. That's what's really, really important here. But you certainly feel the eye drops, right? So you feel the treatment, but you don't feel the disease. So I think we need to do something about it.
So it sounds like we're all pretty much in agreement that there are multiple impacts on the quality of life for our glaucoma patient. One of the biggest of those is the impacts of treatment inflicted by ocular surface disease when we're talking about multiple medications. And Christophe, how do you think things have changed over the last few years with the increasing introduction of phacoplasts, trabecular meshwork, minimally invasive glaucoma surgery? Do you think there's been a change in our treatment goals?
I think that in this increased awareness of the problem we have been discussing about the surface and the impact on glaucoma care, on the quality of life, many things have changed. First, I would say preservative-free eye drops have reduced this problem and the dry and impact of toxic compound. I would also add a fixed combination, because it's also a way to decrease the number of eye drops and improve compliance. Laser, and I would really like to emphasize the major importance of the LIGHT study that showed that finally the patients treated earlier and primarily with laser develop less toxic effect and better outcome. This is very important information. But finally, of course, the discovery that a light surgery, a minimally invasive surgery, tackling not the surface, not filtration, not causing bleb to develop, but tackling the initial mechanism. In fact, the initiation of glaucoma is in the trabecular meshwork. So opening the trabecular meshwork by minimally invasive surgery on one side, or improving the function of the trabecular meshwork with SLT, are the same way to go more precisely in the objective of glaucoma treatment before it will have major consequences on the optic nerve and require more aggressive surgeries.
Yeah, in the past, we've always measured our treatments sort of almost purely on pressure, because we obsess about pressure because it's relatively easy to measure. It gives us a nice, apparently robust number. But do you think there are other things that we now should be considering as treatment outcomes or as successes?
Yeah, I think when you look at that patient, you've got to look at their life expectancy. They're putting in their trust in you for the rest of their life. And I think you've got to think, where is this patient going to be heading? If someone is presented with advanced disease or rapidly progressing disease, you have to think that there's a high likelihood that they may need filtering surgery. And again, you want to try and preserve that conjunctinons as much as possible to give you the best chance of controlling their disease. So it's not just about the IOP or the state of glaucoma at presentation, but you start to have to think about, what is the future for this patient and how can I best shape that? And that's sort of all part of that interventional glaucoma mindset. And I think what Christophe was saying was, with all the options that we have, all the great work that you and your team have done with LIGHT, with MIGS as a whole, we now as surgeons have the opportunity to take control of the disease from day one, as opposed to being a passive passenger. I think that's really been a strong enabler for us as a glaucoma community. And therefore that means that we can act for the patient's best interest rather than sort of seeing how things go at the next visit. And I think that's a crucial mindset change.
Yeah, absolutely.
Do you think we can have different treatment goals now other than pressure? I mean, I suppose what I'm driving at is do you think that drop reduction with the same level of pressure might be a valid outcome, might be a valid treatment goal for trabecular MIGS?
I think for the individual patient, yeah. If there's a patient on one class or one combination drop and you can get them off that drop, that's a big win for that patient. Yes, of course, if their IOP is the same, it may not have a huge change in that particular patient on their prognosis, but for that individual, it's going to change their life.
I completely agree with that. Because before we only had trabeculectomies and tubes. They are very powerful surgeries, but power comes at a cost. So in an early controlled glaucoma, in a moderate controlled glaucoma, we might not necessarily think only of IOP, because this power of our filtering surgeries will come at a cost of infection, of 78% cataract, of 1% per year endophthalmitis. So we do have several risks and some unpredictability with these filtering surgeries. And with MIGS, namely with Ilios, for example, but with all trabecular meshwork procedures, we have more predictability, more quality of life, and easier, faster recovery. So we do think that we're shifting a little bit in our outcome according to the type of patient, to the type of glaucoma. We're trying to improve and look in a more holistic way.
Yeah, I think we've really managed to sort of shift the dial of safety. One of the criticisms of Phaco Plus is that we've also dialed down the effectiveness of the actual procedure, in that the trabecular meshwork procedures are less powerful, as you say, than some of the traditional surgeries. But what we've gained by doing that is a great deal of additional safety. So we've got a much safer and simpler and quicker recovery set of procedures with perhaps slightly less pressure reduction. I'm just wondering whether we still, as a group of glaucoma specialists, we still perhaps underestimate the success of just getting patients off these drops, because there's such a negative impact on quality of life in whole hosts of reasons, not just ocular surface disease, but systemic and periocular side effects. I think maybe drop reduction itself could be a really valid goal, but as a profession, we still underestimate that.
Absolutely. And sometimes patients may feel that eye drops are safer, but we need to remind ourselves that there are risks in anything that the patient chooses and that we recommend to our patient. We need to measure risks and safety for everything, risks and advantage, and medication has risks.
I fully agree. In fact, the problem is certainly to identify what is best objective for the patient. Is it to have the lowest pressure as possible? Is it more to have a compromise between the risk and the benefit? It's the same for eye drops, with potentially a very severe side effect sometimes. And some patients don't talk to the ophthalmologist about their systemic side effects, depression or other effect of beta blockers, for example. But in fact, my opinion that it's not so important to decrease as much as possible, but to have the right pressure that is able to protect. It doesn't mean to be below 10 or between 10 and 12. It means to go to a physiological pressure. It's normal not to achieve extremely low levels with trabecular surgery just because of the gradient of pressure between the anterior chamber and the pressure in the vein, the ophthalmic vein, episcleral vein. So there is a gradient, and we cannot achieve a very, very low level, but in most cases, it's largely enough to protect the eye because it's a physiological pressure that would have been obtained without pathology of the trabecular meshwork or just by opening the trabecular meshwork.
There's also some evidence now, isn't there, from both the SLT trials and some MIGS trials that patient-independent pressure lowering, so medication-free pressure lowering, may even have or offer better visual field preservation than perhaps the medicated patients get, even at the same pressure. Go.
Yeah, I know. We've discussed that in detail as well, and I think we need more work on that. I think generally, as glaucoma specialists, we do tell the patients that as a potential advantage of SLT or MIGS surgery, or in particular trabecular bypass MIGS surgery. So yeah, I think that's a really important consideration. We need work to look at that, to confirm that. And I think, going back to what Christophe was saying as well, the old saying that a good physician treats the condition, whereas a great physician treats the patient who has the condition. And I think, what is the target IOP for each patient is very much different. If a patient comes in and has horrific prostaglandin orbitopathy, but a great pressure, and their life is miserable, is that a success? Probably not. If we could get the that patient off the drops, and even if the pressure was a bit higher, that may be better for that patient rather than just purely thinking about it as the glaucoma-centered metrics.
There's one aspect around the quality of life of the patient is we all think we know what the quality of life of the patient is by talking to them, by asking them. But when it comes to really studying it and measuring it, I've personally had some real difficulties in a big randomized controlled trial trying to show a difference in quality of life. What sometimes people forget is that we did show a change in the quality of life, but it was a change with time. All of the metrics in all of the patients in both treatment arms in the light study got worse. So as you got older, your quality of life got worse. Sadly, I feel that's no surprise. But we didn't show a difference between the two treatment arms. And I think that was a sign of the fact that we maybe chose the wrong instruments. Maybe it's just a difficult task. Have you had much experience, Professor Baudouin?
Yes, this is a question that is also raised considering preservative-free eye drops compared to preserved. Yeah. It's very difficult to show in a short period of time with only one medication major differences, because a normal eye that receives even preserved eye drop once a day for a few years will not experience major changes. It may change weekly in case of ocular disease prior to the initiation of treatment. In that case, probably laser is much better than eye drops, whatever the eye drops. But it will take a long period of time to develop. First, because of aging. Second, because of the accumulation of eye drops and accumulation of toxic compound. And probably because over time it will be necessary to treat with more drugs. So second drug, a third drug, and the major shift in quality of life will appear at that moment when it's necessary to increase the treatment. The treatment is no more effective, and we have to add other eye drops, and this will accumulate. And at that moment, the difference between a little treatment and a more important treatment will become prominent for the patient and the quality of life.
Yeah, and I think we still don't have that ideal patient-reported outcome measure for an intervention like MIGS or SLT. We have good patient-reported outcome measures that can look at, as Gus had said, over a longitudinal time. But for an intervention that has a definite treatment and effect, we still lack that patient-reported outcome measure, which I think lots of people are looking at, but we still don't have that to really help guide us as to what benefit are we affording our patients with these treatments.
It's difficult, isn't it? And it affects every patient in a different way. And a lot of these interactions are non-linear. So people talk about stacking medications. You get less bang for your buck with each additional medication, but you probably get much more impact on quality of life with each additional medication. You get almost an exponential impact on ocular surface disease. And we think possibly on quality of life, but it's so difficult to measure.
Well, quality of life is a very complex, multifactorial component, and I think it's so subjective. That's why we have some difficulty in measuring, and we really need further evidence about quality of life and MIGS, and this is definitely something to work on.
Just thinking now about some of the specifics of which patients really benefit from these procedures, what do you think would be the patient you're most likely to take a trabecular meshwork MIGS, phaco plus Elios laser approach to?
Yeah, I think the ideal patient is someone that has obviously a visually significant cataract and has mild to moderate disease and is on one drop, whether that's one class or a combination drop. I think with trabecular bypass surgery such as Elios, I think we have a really good chance of getting that patient seeing better, obviously with the cataract surgery, and then getting that patient off that drop. So for me, that's the ideal candidate patient.
I have a simple way to explain my indication for MIGS, for trabecular surgery in a patient who was to undergo cataract surgery. When I am between the fact that just there is a large lens, I'm a glaucoma that is very, very mild with only one drop, pressure just at the limit, I can expect that cataract surgery alone will add something and will decrease the pressure. On the other side, when a glaucoma patient has a cataract plus a glaucoma that is not well controlled, that requires treatment that are not well tolerated, and is progressing despite the treatment, in my opinion, this is a filtration surgery indication. So I will perform a combined surgery. But in between, there is a very, very large amount of indication with patient. I would like to decrease more the treatment, the treatment and the pressure, but I don't want to perform a filtration surgery with all complications that has been evoked a moment ago. So in between, there is a large space for this trabecular surgery with minimal risk and a good way to improve the quality of life of the patient.
Absolutely. I would go even further. I think that every cataract visually significant in a glaucoma patient can be an opportunity to do phaco and another associated glaucoma, because we can have mostly in glaucoma patients, namely pseudociliative glaucoma. If we do only cataracts, there might be an IOP spike up to 45%. So there is some risk of IOP spikes increase only of doing cataracts. So I believe that every cataract in a glaucomatous patient is an opportunity lost if we don't add a little gesture. Depending on which type of glaucoma, which IOP, we have to titrate, right? So that's the advantage of having so many surgeries.
Yeah, I think I'd agree. I certainly see any patient having cataract surgery who's on medication for pressure lowering, taking eye drops, as a potential candidate for phaco plus. In fact, I think I'd go one step further and say that quite a few of my patients, where I might have put them off or dissuaded them or deferred cataract surgery for a little longer, if they are on medications now, because we've got the opportunity of phaco plus, it's actually a reason to intervene slightly earlier than I might otherwise have done on purely visual grounds. So in fact, I think my threshold for cataract surgery has dropped because of phaco plus, has reduced because of phaco plus. That's been brilliant. Thanks so much, everyone. I would like specifically to thank Anna Miguel, Ratnarajan, and of course, Professor Christophe Baudouin for giving up their very valuable time to join us here today. It's been a great summary and overview, I think, of some of the impacts that minimally invasive glaucoma surgery can have on improving health-related quality of life in our glaucoma patients. And also a reminder of how severely we can affect our patients with what we sometimes think of as just eye drops. We're aware of the local side effects, we're aware of the systemic side effects, but I think all of us at times are in danger of underestimating how much that can impair their quality of life. And it's great, from my perspective, it's great that TM-MIGS, phaco plus, has allowed us to really focus in on that specific aspect of patient care. Thank you very much for joining us. I look forward to the next one.
Thank you. It's been a pleasure.
Thank you.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLAs GmbH, and the FIDO laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.